important session. We're moving to another important session of the conference, CPC. CPC is always a learning curve for everyone, most for the person who's discussing and some for the others who come here to listen and to participate. Great pleasure in welcoming you all along with the co-chairperson, Dr. Satish Balan, for this CPC. I now invite Dr. Priyamvada to come and start the proceedings. It will be there for 1 hour, 20 minutes for initial presentation, 10 minutes for discussion and interaction with the audience, and 20 minutes for pathology discussion, and then another 10 minutes for the audience interaction. Over to Dr. Priyamvada. Dr. Satish Balan will introduce it.
Yeah, welcome to the CPC. It's always a fun exercise. We are CPC except for the person who's presenting, who's having a tough time of it. So to present Dr. Priyamvada. Priyamvada is well known to all of you. She is the professor of nephrology at JIPMER right now. She's a product of Calicut Medical College, and she's very interested in clinical research, glomerular disease, and a host of other subjects. An excellent teacher and also discussant, and I think she will make a very good job of the CPC here. So over to Dr. Priyamvada.
Thank you for the nice words of introduction. So let us move on to the case. So it's a 37-year-old male who was having CKD stage 5. He was on maintenance hemodialysis for a period of 2 years. He underwent a live-related kidney transplant surgery. Mother was the donor. So there is no reason given why actually he was on 2 years on maintenance dialysis program, and I am not provided with any of the pre-transplant details like native kidney disease, what was his cross-match status and all. And the induction given was with the basiliximab, basiliximab 20 milligram was given on day 0. And there is no detailed description of what happened during the surgery, but it is stated that the surgical complications were not there. But the patient had anuria, and again it is not known when the anuria started, whether there was urine output immediately after the anastomosis or whether it happened later. It's not clear from whatever case history given to me. So at the end of 8 hours post-transplant, a renal Doppler was done, and the Doppler showed reduced flow to the upper and the lower port. So the patient was planned for a re-exploration. And again, re-exploration findings are not given, whether there was any major or branch vessel occlusion, that is unclear. And a renal biopsy was done, and the surgery was closed. So the next day, it was found that there is a drop in hemoglobin levels and platelet counts. And as you can see, by day 3, that is the 3rd of October 2020, it's pretty apparent that there is a drastic fall in the hemoglobin and the platelet count. So clinical picture was consistent of a thrombotic microangiopathy, and plasmapheresis was started on post-operative day 5. And patient received 5 sessions of plasmapheresis on alternate days. And along with this, the patient was given intravenous immunoglobulin as well as hemodialysis. So by this time, the kidney biopsy report has come, and it has been reported as a C4d negative thrombotic microangiopathy. So around 7 to 10 days, the platelet counts and hemoglobin started to improve. It showed a definite response to plasma exchange and IV immunoglobulins. But basically what was happening was the anuria was persisting. And the patient has been received 10 sessions of hemodialysis. Even though the platelet improved, the LDH has come down and hemoglobin improved, there was actually no urine output. And during this time, no details of immunosuppression was given, apart from the fact that only plasma exchange and IVIG was given. I don't know whether any other immunosuppression, whether CNI was continued during this time, it's not given. Then because of persistent anuria, around 2 weeks after the initial surgery, a repeat kidney biopsy was done. And the diagnosis from the repeat kidney biopsy was acute T-cell mediated rejection, BANF 2A. And the patient was started on ATG 2 milligram per kilogram in divided doses on 17th of October and 19th, along with pulse methylprednisolone. So it's also unclear whether actually pulse methylprednisolone was given and subsequently ATG was added, but the description sort of gives me an impression that both of them were given simultaneously, and again reasons are not mentioned. And low-dose tacrolimus was started. It was increased to 2 milligram BID with the attaining a TAC levels of around 10 nanogram per deciliter. So after this ATG and steroids, there was a gradual improvement in the urine output. From day 15 onwards, the patient started producing some urine. Till then, the patient was anuric, and there was a very gradual fall in creatinine. And the patient was discharged once a steady downward trend in creatinine was documented. And somewhere around 28th November, the creatinine documented was 3.2 milligram. So this is all what is provided to us from the history, and the genetic analysis report also has been given. It did not show any, an NGS was done which did not show any pathogenic mutations. By the time the factor H antibody levels also came, and it was negative. So basically, the key issues for this patient is there is delayed graft function, and we don't really need to bother too much about the delayed graft function in this patient because the biopsy reports are already given to us. And there is a post-transplant TMA documented on the same day of transplant. And the patient, that was a pretty bad thing. The patient remained anuric. And we don't know what is the cause of that post-transplant TMA. That is where actually I'll be focusing most of the discussion on. And the post-transplant TMA recovered, but that was followed by a cell-mediated rejection ban of class 2B. Now, coming to post-transplant TMA, whenever we see a patient who develops a post-transplant TMA, the first question that comes to our mind is whether it is a recurrent TMA or whether it is a de novo TMA. And the disease is not very uncommon. The prevalence varies from 0.8% from large databases and up to 14% from single center studies. But of all the TMAs which happens after the post-transplant, usually de novo TMAs are going to be much more common than recurrent TMAs. And there are two forms. The systemic form is easy to pick up because there will be microangiopathic hemolytic anemia and thrombocytopenia, and there might be acute kidney injury, varying levels. But localized form often is revealed only by a kidney biopsy. It can present as isolated AKI in the absence of any microangiopathy or thrombocytopenia, or it could actually come as a slowly progressive graft dysfunction sometime later in the course of transplant. And sometimes the manifestations could be subtle like proteinuria or difficult to control hypertension. So the most important question here is whether it's a recurrent or a de novo TMA. And this is where actually the previous history is going to be very important. And whether it is recurrent or de novo, does the timing of this TMA help us to identify, classify it as a recurrent or de novo? Most of the time it's not going to be helpful. Even though TMA can happen any time after transplantation, most of the episodes of TMA are common in the first 3 months of transplantation because there are so many complement activating events which can actually, or vascular activating events which can actually happen in the initial months of the transplant. For example, the ischemic reperfusion injury, especially donation after cardiac death, the warm ischemia times are prolonged, and this can directly upregulate the complement and the thrombin system on the vascular endothelium. Then the drugs. Most often, CNI is implicated as a cause of post-transplant TMA, but again, the data is from an era where actually complement testing is not widespread. So the present consensus is probably CNI is one among the various factors which actually might potentiate a TMA. And mTOR inhibitors are also associated with TMA, and in fact, it was actually considered as probably an alternative to CNI because there won't be much TMA. But again, it has been found that mTOR inhibitors can cause downregulate the vascular endothelial. It can cause apoptosis to the vascular endothelium, reduce the vascular endothelial growth factor, and that could actually be a trigger for TMA. And in certain series, TMA is as common with mTOR inhibitors like the same proportions reported with CNIs. And the other thing is a lot of post-transplant infections can actually trigger a thrombotic microangiopathy process, and rarely donor-related issues like the cause of death, especially donation after cardiac death, prolonged ischemia times and all can also upregulate the complement and the thrombin system. And there are few things which actually tells that probably this might be a recurrent TMA. The most important thing is a previous history of TMA or at least a documented genetic mutation, in the absence of which it is pretty impossible to diagnose a recurrent TMA in the graft, especially if it manifests only after transplant. Usually rapid onset, systemic TMA features and extrarenal features tends towards the presence of a complement-mediated event, which probably would have been there prior to transplant or which probably would have been overlooked, but these are not absolute. So, coming to de novo TMA, which is the most common cause of TMA after the transplant. So I'm not actually going into the other causes of TMA. Technically, any cause which causes TMA in the general population can cause TMA in the transplant patient. But here we have a biopsy which is actually proven of TMA, and there are a lot of TMA mimickers also. But since the biopsy is having a TMA, I thought I'll start my discussion. I thought I'll start the TMA as my starting point of discussion. So the most common two causes of de novo TMA after transplant is complement-mediated TMA and antibody-mediated rejection. The complement-mediated TMA probably can happen in multiple situations. The patient might be diagnosed to have some other native kidney disease, and there might be silent complement gene abnormalities which probably was not manifesting prior to the transplant. And probably the milieu associated with the transplant acts as a complement activating trigger, and of course we know that for many complement mediated disorders you need a second hit, and transplant acts as a second hit, and the disease manifests as TMA in the graft. The second situation is probably they had a TMA, and this was overlooked, and it would have been diagnosed as maybe accelerated hypertension or malignant nephrosclerosis, and probably we have completely missed, even if the setting was there to suspect TMA, probably the diagnosis would have been completely missed, and a rare, pretty unusual situation is a phenotypic shift of C3 glomerulopathy to HUS post-transplantation. The other reasons include immunosuppressive agents, mTOR inhibitors and CNI, and sometimes induction agents like anti-CD52 antibodies, and viral infections like HCV, CMV, BKV, COVID, and parvovirus. Here, I don't know whether actually the drug has acted as a trigger. The only thing which was mentioned along with the history was basiliximab induction was given. I don't know whether tacrolimus was given prior to the transplant, because there is quite a lot of center-specific variations in prescribing CNI levels. Whether any mTOR inhibitor was given as part of induction, that is also unclear. And infections, yes, technically possible, but basically the TMA happened within a few hours of transplant. And usually all these infections would have been ruled out, or if at all these infections were there, it would have been taken care of, and it is very pretty early for a CMV and a BKV to manifest within a couple of hours of transplant. The other thing is the great COVID is there. This was done during a COVID time, and we know that actually COVID can present. COVID can invade the endothelium directly or through indirect mechanism, and COVID is capable of producing endothelial injury and TMA. But again, from the history, there is nothing to suggest of COVID, because the usual COVID-related TMA is described in the setting of lung disease. Some COVID pneumonia might be there. A totally silent COVID just going and attacking the vascular endothelium and the kidney, probably I feel the chances are rare. So now what is left out? What is left out is an antibody-mediated rejection and complement-mediated TMA. So let us come to the TMA recurrence. There are multiple mutations. This list is not actually all inclusive, but there are multiple complement mutations which can actually cause an atypical HUS, and that can actually lead to a recurrence after the transplant, of which CFB and C complement factor I are the mutations with the highest recurrence rate, which are placed as a high risk for recurrence, and CFH and C3 closely follow. Some modest risk of recurrence is there, and the other mutations are quite a little bit. MCP has a pretty less chance of recurrence, and thrombomodulin, diacyl glycerol kinase epsilon and all, the recurrence rates are pretty less, but everything is documented. So now here the first question is whether this is a recurrent TMA. It's very difficult to tell without actually knowing the past history, and whether the transplant acted as a trigger which activates the TMA. For that, I need the data on ischemia times, whether the patient had any sensitization events, cross-match status, then the details of immunosuppression, infections, and native kidney disease. So without any of this history, it's practically impossible to tell whether it is a recurrent or de novo TMA. Now, coming to the question whether actually Mr. G, that's our patient, is having a de novo complement-mediated TMA. As I told, it can happen in three situations. One is a genetic patient diagnosed to have some other native kidney disease but harboring some genetic mutations in the complement cascade, then the misdiagnosis of thrombotic microangiopathy, and a phenotypic shift of C3 gene. So let us see how common is it. Recent studies, actually there is a paucity of studies, even though data on literature on post-transplant TMA is overwhelming. There is not much of studies which actually has really looked into the complement component abnormalities. This is a recent series of around 24 patients with a recurrent TMA. They had tested whether there is an underlying complement dysregulation. So it has been found that around 29% of the patients for whom complement testing was done was found to have CFH or CFI gene mutations. They did not come across any other mutations. And clinical features was not really helpful to distinguish these patients with mutations and without mutations. And if you can see, none of them had any clinical grounds to suspect a complement-mediated kidney disease. And in fact, they had other alternate diagnoses like vesicoureteric reflux, Alport nephropathy, nephrangioschlerosis, and undetermined renal disease. So it is possible. So if we extrapolate this figure, 1/3 of post-transplant TMAs have complement gene mutations. Well, it is very well possible that our patient can harbor a complement component mutation. We don't know what was the native kidney disease, so it is possible that it could be overlooked. Okay? The second situation is probably a chronic TMA can be misdiagnosed as a hypertensive kidney disease. There might be underlying complement mutations, but since the patient does not present with any hematological manifestations, it could be easily overlooked. And of course, the same thing happens in pregnancy-associated HS, but it doesn't matter here because we are dealing with a male patient here. So the next situation is the native kidney disease might be a C3GN. And the C3GN generally does not tend to recur that much compared to HUS, but there are certain case reports which has reported that patients with a phenotype of C3GN pre-transplant, they have undergone a phenotypic shift post-transplant to atypical HUS, then this is going to be, of course, rare. So here, we are provided with the complement component workup. An NGS was done that has not detected any mutations. But here again, we have to see that ADAMS13 gene is sequenced, but ADAMS13 levels are not available. And in adults, usually acquired ADAMS13 deficiency is much more common than congenital ADAMS13 deficiency, which is a disease of early childhood. And again, how reliable is NGS in ruling out complement component mutations? We can see that many of the common genes which cause HUS, NGS covers 100%. But NGS comes with a drawback. NGS is very good in detecting point mutations, but the problem is if there is a change in the gene copy number, if there is a deletion or if there is a reduplication, NGS is not the answer for that. We have to go for some multiplex assays or PCR or microarrays. So 10 to 15% of all genetic mutations are associated with changes in the DNA copy number. So what we can say after NGS is there is no point mutation, there is no point mutation which is responsible for, there is no point mutation or there is no premature chain termination which is responsible for an abnormal complement component in this patient, but a mutation resulting from a large deletion or duplication still is outside the radar in this patient. And whether the complement component levels are going to be helpful, in many situations where there is a complement mediated TMA, it has been found that the complement levels can still be normal. So I don't really know if we were supplemented with the complement component information in data on individual complement component levels, whether it would have been helpful or whether it would have been pointed towards the possibility of a complement mediated HUS. I'm not really sure in this situation because there is not much of supportive data to tell that actually if a genetic testing is available, we should again, if it's normal, and we should again go and look back at the complement. Complement and thrombin. This have a sort of bidirectional relationship. We know about the 3 complement pathways activation, but mannose-binding lectin pathway and thrombin activation are inherently linked. MASP can activate the thrombin, and thrombin in turn can activate the complement. So any situation where there is a complement activation occurs, irrespective of the reason, it is not surprising to see major vascular thrombosis also. Because in this patient, there is some description that there has been a reduced flow to the upper pole and the lower pole. So we don't really have any data on the re-exploration, whether there's a patchy cortical necrosis, because the first biopsy need not essentially pick it up because it's too early. So that part is unclear. So the next question is whether this TMA is a manifestation of antibody-mediated rejection. So for antibody-mediated rejection, We need a histological criteria which could be in the form of glomerulitis or peritubular capillaritis, or events like ATN or thrombotic microangiopathy without any obvious cause. And we need an evidence of linear C4D staining, or in the absence, we have to have some gene transcripts which are upregulated during antibody-mediated rejection, and a serologic evidence in the form of DSA. So here we are not provided with the DSA data. Let us actually have a closer look at the kidney biopsy. So kidney biopsy says that only it's an inadequate biopsy as per the Banov criteria. It's only 9 glomeruli, and 1 glomeruli is globally sclerosed, and the other glomeruli shows prominent congestion and thrombi occluding the capillary lumen, and there are some neutrophils also. So whether these neutrophils qualify as glomerulitis, we have to actually see. It's not really quantified in the biopsy. And few tubules have hyaline cast with a tubular injury, and there is some there is no tubulitis, but there is some mild peritubular capillaritis. So is it PTC 0 or PTC 1? And again, we have to actually wait for the pathologist to tell us. Immunohistochemistry shows non-circumferential C4D positivity. So basically, it's very clear that there is no G2 or G3. But whether it is a G0 or G1, it's not clear from the description. We need some quantification of the glomerulitis here. Similarly, it's very clear that there is no PTC 2 or 3. But PTC 0 versus PTC 1, again it's up to the pathologist to tell us what grade of PTC it is. And again C4D, larger grades of C4D positivity is not there, so whatever C4D the pathologist has reported, whether it qualifies as C4D 0 or C4D 1, again we have to listen to the pathologist for this. So now
your time is almost over.
Yeah, I'll finish. Now, the next question is whether it is a C4D negative antibody-mediated rejection. So, approximately 20% of the rejections are C4D negative, and in the absence of C4D negativity, we should have a G plus PTC score more than 0, and DSA is going to be mandatory for making the diagnosis. The problem with the C4D is not a universal marker, and C4D tends to be negative as we move towards smoldering rejections and chronic active rejections. And systematic reviews and meta-analysis have actually shown that the sensitivity of C4D is not very great in diagnosing antibody-mediated rejections. And C4D should not be taken as an equivalent of DSA, because all DSAs does not always interact with the endothelium, and certain DSAs does not actually activate the complement, and probably rather than the DSAs, it's the intragraph transcriptome which is actually much more important, which shows that the DSA has started interacting with the endothelium. And there might be technique related issues also. C4D, frozen IHC and immunofluorescence are usually the commonly used techniques, and the inter-observer variability is going to be much more higher for IHC compared to immunofluorescence, and the inter-rater agreement or inter-method agreement between IFC and IHC is also not that great. So while interpreting the C4D findings, we have to actually take these matters into consideration. And again, the discriminatory power of C4D as something which distinguishes from complement-mediated TMA and ABMR is poor. 10% of the complement-mediated ABMRs, complemented-mediated TMAs will demonstrate some amount of C4D positivity in the tubules. So basically,
I think
yeah, we have to look at the DSA. So DSA is going to be the answer whether it is a C4D mediated, whether it's a C4D negative TMA or not. So my diagnosis is a TMA because of ABMR. It's possible. We have to have a closer look at the G and PTC, and I need the DSA. So why he has developed an ABMR? 2-year dialysis vintage is there. We don't know whether any sensitizing events are there. We don't know the cross-match status, what type of cross-match has been done for the patient. And the unusual causes like antiphospholipid antibody syndrome also has to be looked into. And the second biopsy is a clear-cut, there are no ambiguities in the second biopsy as far as I could see. It's a cell-mediated rejection. And why there is a cell-mediated rejection? Possibly, I believe that the TAC and MMF TAC probably might not have been started because of the delayed graft function. Probably that might have been the trigger which actually has led to the cell-mediated rejection. So this is my diagnosis, post-transplant TMA in the background of active ABMR, which is C4D negative. I need DSA for confirmation, and the events which actually has transcribed to the ABMR probably might have led to a reduction in immunosuppression, and that has culminated in a T-cell mediated rejection.
Thank you, Dr. Premada, for that nice discussion. Just before I throw open to the audience a couple of questions, I sympathize with you that a lot of details are not available in the dialysis period, blood transfusion, hepatitis C status, cross-match status, nothing is known. Just given the data, and also we do not know what immunosuppressive agents were used at induction apart from basiliximab. Just 2 points. An accelerated hypertension also can cause TMA. You do not know what was the status of blood pressure
Yes.
during induction, during the surgery, and post-transplant period. And of course, antiphospholipid antibody, which you just briefly mentioned in the end. In fact, we had one patient with antiphospholipid antibody who had TMA and was antiphospholipid, that despite giving low molecular weight heparin prior to transplant, covering during the period, she had, but she's doing well about 18 years down the line on oral anticoagulants now.
Yeah, sometimes APS can be misdiagnosed as a hypertensive kidney disease. Or if we don't do biopsy, we can even attribute the subnephrotic proteinuria to a glomerular disease also. The other situation is lupus. Obviously, there's nothing in this patient. A lupus sometimes actually can have a catastrophic APS post-transplant.
Satish, comments before we throw it to the audience.
Yeah, just to see, one of the important things here we see is the second biopsy, there is absolutely no TMA. It is clean, the second biopsy.
Yes.
So when I look at a transplant and on top of the list, things I don't want to see after transplant, right on top of the list will be TMA. So if a TMA occurs and disappears, that's fantastic. I don't know what type of TMA is that it disappears. Do you really seriously think this could be an ischemia reperfusion injury?
So that is why actually I am thinking more in terms of a C4D negative antibody mediated rejection. Of course, actually DSA is the final answer here, which I am not provided with.
I'll leave it to the audience. Any comments from the audience?
Yeah.
So if you please be brief and...
Yeah, at the outset, I must basically appreciate the way the speaker has discussed and did an extremely good job with the limited data what she has. But I agree with your finding that it could be an ischemia reperfusion injury because TMS is often a two-hit theory. I mean, there is a mutation which is lying very silently, which requires only one more hit to be precipitated. That can come in the context of a CNI, pregnancy, or an ischemia reperfusion injury. So that's a point very well taken. But my point is an ABMR in the context of modern cross-match techniques with C4D negative, probably on-table rejections are a history.
Yes.
I have a difficulty in accepting it's an ABMR in the context of a good cross-match. Now, having said that, I'm trying to lean towards a non-HLA antibody-mediated C4D. And then again, in the pathology, I have a problem with immunohistochemistry. C4D by immunohistochemistry, even if you see a faint trace, the current recommendations is you need to interrogate it further with an immunofluorescence, which is a gold standard. So I always ask my pathologists to stain it with immunofluorescence, and they usually oblige. On the paraffin block, if you have even a minor speck, it warrants it to be interrogated with an immunofluorescence. So those were my observations, but again, excellent discussion. I enjoyed the talk all through. Wonderful.
We have no idea about the cross-match, and basically the two key things missing here is the cross-match data and the DSA. I believe that the CDC is negative.
I don't think it's HLA mediated at this point.
Yeah.
No, it is very good discussion. And my opinion, one is absence of C4D in the first biopsy is one. Clinically, it is looking like ABMR only, unlikely to be TMA because of genetic factors or some other. The reason is C4D, the biopsy first we have done is immediately after the re-exploration. That time it might not be there. It takes some time, at least some 6 hours or 24 hours. That might be the reason. And in the second biopsy, all the TMA has disappeared. That also goes in favor of antibody-mediated rejection, which is resolved. Suppose if it is a genetic cause of TMA, which is unlikely because we have not given any complement like eculizumab we have not given, and we have not given any FFP also. After 4 or 5 sessions of plasmapheresis, it disappeared. That also goes in favor of antibody-mediated rejection, unlikely to be TMA based on these two. Either it is HLA mediated or as most probably non-HLA related antibody-mediated rejection also one possibility if DSA is negative and previous cross-matches information is there. So we need DSA, but overall clinical scenario it goes in favor of antibody-mediated rejection and unlikely to be TMA.
Antibody-mediated TMR, whether it's HLA or non-HLA, that's a question.
Yes.
Okay, thank you. Any other opinions from the crowd, Rajesh?
It's a wonderful discussion, but just one doubt. When was this anti-factor H and ADAMT sent? Is it after plasmapheresis or before plasmapheresis? It's a very important question.
Actually, it's not given in the description. Only I was provided with a sentence that anti-factor autoantibodies was negative.
Important point. I think everybody is in favor of the notion that it's an antibody-mediated rejection.
But such an hyperacute rejection, antibody mediated, generally doesn't go off like this and no remnant, this one, no thrombotic microangiopathy, the second biopsy. Such an accelerated hyperacute rejection is on the table. It looks like on the table, generally doesn't go off like that.
It just doesn't go off. I personally favor the ischemia recoefficient theory, but let us see what happens. I think thank you, Dr. Priyamada, for an excellent discussion and for a run through about what TMA after transplant is. TMA after transplant is generally not good, but this patient seems to have survived that. Let's see what's the. Please take a seat, and I will call the